the special COVID webinar. None of us probably imagined that we'd still be facing these challenges in the second half of 2021, but we continue to have some pressures on our frontline workers as COVID surges throughout Sydney. So I'm particularly grateful to have all of you with us today, and in a moment I'll introduce our panelists. That many of you would have seen in the last few weeks the critical role that St Vincent's has played in responding to this more recent case that surged across Sydney. All of you would have seen the critical role that St Vincent's has played in terms of testing, the role that we are playing in terms of vaccination, but very importantly, you would have all seen the various roles we're playing in treating patients across the board at different levels. And some of that treatment is taking place in our intensive care unit, some of it is taking place on the wards, and very importantly, a lot of this care is taking place in the community with our virtual hospital in the home unit. But either way, St Vincent's is certainly in the hotspot at the moment, playing a critical role. And it is, when I say it's a pleasure to be here today, I really mean that in the context of so much of this critical response that we've been able to provide has been enabled by the St Vincent's Curran Foundation. So in a moment, I'm going to introduce our panelists, but what I do want to say is we're very privileged to have the panelists with us and for them to make the time to be with us. But at the same time, I can speak on behalf of all the panelists in saying we feel very privileged to be with you this evening. You've played a really critical role. I know all four panelists are extremely passionate about their areas of endeavour, but at the same time, we're all united in feeling very passionate and very grateful for the community support that we have that fuels our critical response that we're playing right now. I'll introduce the panel to you now, but I'm quite chuffed being in this role today because the panelists we have are probably the busiest, certainly the heavyweights on the COVID front on the St Vincent's campus. Many of them don't return my calls, so I'm quite chuffed to be host today because I've got a captive audience and I can ask them all the questions that I've been wanting to ask, and they have to answer my questions now because it's a live webinar. So I feel happy to be here, but I'll introduce you to this panel of heavyweights right now. Danielle Austin is, if you want to raise your hand, Danielle, is the Incident Response and Disaster Manager at St Vincent's Hospital. Sean Evans is the Mental Health Services Manager at St Vincent's. Courtney Lace is our COVID-19 Nurse Manager. And Professor Gail Matthews is Head of Infectious Diseases at St Vincent's. My role in coordinating media, I'd like to think that all of our panelists are fairly well known to all of you because all of them have played quite a key role in engaging with the community, doing a lot of media for St Vincent's in terms of telling our story and engaging with the public to provide them with a lot of reassurance and education about COVID. This is a journey that we're all experiencing in real time. And so it's great to be able to have these key commentators who are really at the forefront of our COVID response, and particularly for the purposes of this webinar now. Just to give you a bit more detail about our panelists, Danielle Austin is, as I mentioned, the Incident Response and Disaster Manager at St Vincent's, and she's currently leading the COVID-19 vaccination program. Over the past 18 months, Danielle has been involved in the hospital's COVID-19 response, initially setting up the organisation's first COVID testing clinic on site, and then at Bondi, at East Sydney and Rushcutters Bay clinics. And no doubt all of you have seen those clinics on the news pretty much every night. They've played a critical role, and certainly when we saw that the Bondi cluster initially about 5 weeks ago, You could see those testing clinics doing a lot of the heavy lifting in terms of screening. Last year, Danielle was awarded the CEO Nurse of the Year award alongside her colleague Rachel McFarlane in recognition of her work in setting up these testing sites. Sean Evans is the Mental Health Services Manager at St Vincent's and has been working in mental health for nearly 15 years in the UK, in Australia and New Zealand, primarily as a mental health nurse, but with experience working in mental health leadership in both clinical and managerial positions. In Sean's current role, he oversees acute inpatient services, community mental health services, and other specialist mental health teams. He is chair of the St Vincent's Mental Health Clinical Governance and Policy Procedures teams. Welcome, Sean. Courtney Lace is the COVID-19 nurse manager, but she's normally our nurse unit manager of the St Vincent's Heart-Lung Clinic. Courtney's role includes getting the wards prepared for COVID-19 admissions, preparations of PPE and stock, physical setup and line markings, nurse education and identification of new learning opportunities for our frontline staff. Professor Gail Matthews is an infectious diseases physician and is head of infectious diseases here at St Vincent's Hospital. She's also program head of the Therapeutic Research and Vaccine Program at the Kirby Institute, where she is conducting a number of international COVID-19 therapeutic trials. Many of you would have seen a lot of the coverage internationally of the ADAPT study that Gail is kind of leading. And we're going to have an opportunity to talk to Gail about some of her findings and some of those long-term studies that she's doing. I know virtually not a day goes by that I don't receive a media call asking for Gail's insights, and certainly she is a front runner internationally in terms of those long-term impacts, but obviously is playing a critical role right now in terms of COVID treatment and COVID response. So on that note, I might open with you, Gail, and ask you just to outline some of the initiatives in terms of treatment that you've kind of introduced and been involved with in the past 18 months in treating COVID. And then if you could also describe some of the more nuanced treatments involved in now the more infectious Delta stream, and maybe some of the changes that have been involved in the past few weeks in that treatment response.
Yeah, thanks, David. So look, I think when we're talking about the treatment response to COVID, we can think of it in many different ways. In fact, therapeutics for COVID haven't really come that far since last year. We're a little bit more sure of a couple of drugs to use, but all of them have to be honest, shown only moderate benefit in sort of changing the outcomes of the patients. I think what really needs to be highlighted is the heavy lifting that's being done in the treatment and care of these patients, just in terms of their general care, the way they're being looked after on the wards, and acknowledging the work of ICU, the COVID wards, and in fact emergency as well, in really assessing these patients, because really we haven't got a lot of new sort of therapeutics to offer them. We know now that, for example, steroids are very important. Steroids have been around for a long time, and we have an antiviral drug called remdesivir, and we have an IL-6 monoclonal called tocilizumab, which we do use, and we're using it where we need to in our patients. But these are not really the mainstay of care. The mainstay of care is supportive, and it's oxygen, and it's really providing that exceptional level of care that is going on in the hospital at the moment. I think there's also something about, so the infectiousness of the virus hasn't really changed our treatments as such, but what it has changed, I think, is our need to respond quickly and in an agile fashion to how quickly the environment around us is changing, and what's going on in the community. And every day there seems to be changes in so many things to do with policies and practice. And I think what I am really proud of at the hospital is we've really managed to set up, a very good system for sort of pushing the policies through that we believe are going to impact patient care the best, whether it's around testing, whether it's around staff surveillance, whether it's around some of our other protocols in the hospital. We've done that by forming what's called a clinical reference group with, you know, the nursing and medical leads of ED and ICU and thoracic medicine, infectious diseases and infection control, and sort of coming together and really quickly being able to cope with the questions and the issues which arise again and again in the way that things are changing so rapidly for us. And I think, you know, having a system within a hospital that can provide that communication and make those decisions is really critical in terms of its impact on patient care and how patients get managed.
Gail, in terms of those patients you see in the more acute setting, those who become more unwell from COVID, how do, and this is a very simple question, but how do they actually become unwell? And number two, how does that interact with comorbidities? What's the influence there or the interaction? I know that's a very basic type of question, but sometimes there's not actually that much clarity around something so simple.
You know, I think we talk about the Delta variant, but it's clear that in many ways, this is presenting in the same way as what we knew right from the start, or what we've learned along the way, I should say. So for the majority of patients, this is still a mild to moderate illness and can be managed in the community. We've got really good ways of looking after these patients in the community by being able to monitor things like their oxygen saturations, their temperature, blood pressure at home by a virtual system with nurses sitting in the hospital who are on the phone to them and measuring these outcomes. And we know that when people tend to get worse, it's actually not in those first few days, but it may be sort of between day 5, 6, 7, 8, so a week or so into the illness, when it's really important that we keep a close eye on patients that we are managing in the community. It's important we keep them in the community because we don't want to overload the hospital, but it's important that we have that way to keep an eye on them. And when people do get unwell with COVID, it normally is with that respiratory problem, with decreasing oxygen saturations, not necessarily recognizing that they're too short of breath actually at the start, but when we check their oxygen, we find it's incredibly low, and then they can really deteriorate very quickly. And that's why, again, going back to, it's so important on the wards to have that high level nursing and medical care that they're providing, so that if a patient starts to deteriorate, they can be moved to intensive care if they need that extra level of respiratory support. So it's still, in terms of your question, it's still predominantly a respiratory illness, but we know there are complications in terms of clots, in terms of heart problems, in terms of brain problems, confusion, delirium. And of course, I'll talk later maybe about the more long-term side effects of COVID-19. In terms of comorbidities, again, we know a bit about what makes you more likely to have a worse outcome from COVID-19, and it is still those people who are older. I know there's been a lot of media about young people, and we can talk a little bit about why that is and why that's important in a bit. But still, in terms of people who do poorly with COVID-19, it is predominantly the older patients and people who have other histories of things like heart disease, high blood pressure, diabetes, people who are significantly overweight, etc. So those, what we would call comorbidities, are still very important in identifying the patients who are most likely to have a more difficult course in hospital.
Am I right in thinking that with the Delta strain, this is certainly a question I probably was posed about 5 or 6 times today, that we're seeing slightly, in terms of Delta, a slightly younger patient cohort and a greater absence of comorbidities, or is that just a bit of speculation at this stage?
No, I think that's true, but the reasons behind it get, I think, a little bit unclear. So some of the rhetoric behind that is that Delta is more aggressive in young people, or it's a more aggressive virus that's killing young people more quickly, this kind of discussion. I don't think we really have any evidence to suggest that's the case at the moment. In fact, if you look at the UK data, Delta is actually less likely to be fatal. And there are some biological plausibility to why that is, as well as viruses change. They become more infectious, but actually less deadly as they get sort of a survival advantage. So I think what we're seeing two things. So what we're seeing is that this is an incredibly transmissible virus. So it's moving very quickly through communities. And what we're seeing is, even in Australia, we are seeing a skewing towards, because the more elderly population and people with comorbidities tended to be the ones getting vaccinated first. What we're seeing is, because so many more people are being infected, is now we're seeing proportionally more people who are younger without comorbidities come in. So these people always were at risk. It's just that proportionally they were much less at risk than this other big group of people with comorbidities and who are older. And now we're sort of protecting those, but we're not protecting the younger people.
But to some degree, Gail, that kind of validates the prioritisation of the more vulnerable and the elderly, and the approach that Australia has taken, correct?
Well, you know, so the only real way to deal with this is to vaccinate everybody. You don't want anybody to be at risk at all. I can understand when you have a limited supply of vaccine why you prioritize to those people, because they're the ones who are most likely to have poor outcomes. But you don't want then that to be reflected by younger people having, you know, being at risk. So that's not a situation that's ideal in any sense.
No, that makes sense. Sean, I might open up to you if that's okay. We know that COVID's put a lot of pressure on people in terms of financial impact, insecurity, uncertainty. Loneliness is particularly a big issue at the moment. Managing working from home, homeschooling. And I wanted to ask, how is COVID-19 manifesting itself in terms of the well-being of our community? What are you seeing at the moment, Sean?
You know, it's quite clear, David, that there is this very prevalent increase in community distress, and that's really to be expected. And I think up until recently, I think people still felt that was something not to be discussed. You know, the fact that people are doing it hard. And in fact, I'd probably say everybody on this call and everybody who's listening in today will have had times in the last 18 months which have been particularly challenging, and COVID and the subsequent consequences of living in a more socially isolated environment as what we live in today have definitely contributed towards that. In terms of from a mental health service response, we're seeing elevated distress. We're seeing it with all ages. We are seeing a particular spike with younger people who have fallen out of their usual routines, but that's applicable right across the age span. People are out of routine. People are out of the things that they would usually do, whether consciously or unconsciously, to maintain sort of health and stability and well-being. We're seeing that additional impact of, you know, of families having to homeschool, of people cohabiting in somewhat unnatural circumstances. We're typically social creatures who, you know, we vie for human contact, and we'd like to see that diversified. It's definitely safe to say that these have been incredibly challenging times, and I think one of the things we try and rephrase is it's become the term that we are, you know, socially distanced, and I think it's important that we kind of look at that being physically distanced but socially connected. We find the ways and means in which we can stay bound together and form a sense of community despite these really challenging circumstances.
Sean, we hear this term used a lot, but can you describe to us the importance, particularly in the mental health and the mental well-being context, of a multidisciplinary approach? What does that mean, and what is its importance?
The real clear thing that I want to convey about the importance of a multidisciplinary team is that it's not just a composition of one source of health professional. It's a diversified range of health professionals that contribute towards the healthcare system, and ultimately an individual, a consumer's care is at the center of that. And that person themselves plays an integral role in how we plan and deliver care. And I think one of the things that COVID has really demonstrated that it is more than nurses and doctors. We see our allied health professionals, our social workers, our occupational therapists, our physiotherapists, all playing really key roles in how we've kind of developed and put in place plans and practices which support our community with their mental health. Even looking internally at EOC, our Emergency Operations Centre, some of those key roles are being performed by allied health professionals. Everybody has this really important perspective which they're able to apply both professionally and personally into how we provide care for those consumers who are at risk.
Sean, as you speak, I keep thinking of everything you're saying in the context of the current lockdown, but clearly COVID's having a broader impact as well. And obviously with lockdown, everything's that much more acute from a mental health well-being perspective. But what are some of the things beyond this lockdown? What are some of the trends and some of the specific concerns that you have in the long term as we do eventually come out of the lockdown phase? What are some of your concerns about COVID in the long term?
I mean, they're quite ranging. I think, you know, we're seeing a progression in terms of people experiencing that distress and how it manifests. And when I say how it manifests, I'm talking about those developed coping strategies, which have probably started as quite minor things. So, you know, an increase in substance use. You know, we're seeing an increased risk of an increased rates of domestic violence in amongst families. We're also seeing people self-reporting higher distress in the community. We're seeing that manifest as depression and anxiety. And without treatment and without early intervention, those things eventually become quite significant healthcare challenges. And it can have a really longer-term detrimental impact on somebody's health and also the family and that person's social environment health. The other really important thing to think about right now is mental health consumers, and certainly those who are open to the more acute services that we provide, are often at a place of disadvantage socioeconomically. Now, this isn't everyone, but the research at the moment, what it's suggesting is that if you are somebody with a diagnosed depression or a psychosis, you're 2 to 4 times more likely to die from getting COVID. And that's often associated with access and equity to access to such things as vaccines. So it's really important that when we're considering vulnerability, and Gail's talked about the comorbidities that would increase somebody's risks of mortality associated with contracting COVID, I'm talking about some of the social and mental health risks associated with that. If people aren't provided the right education in the right context, then they may not have the access, they may not think to get the vaccine, they may need additional support to get a vaccine. And I've got to say, huge compliments to the services that I work with and the approach that's been taken by the likes of Danielle, who's coordinating these vaccine hubs, but also the Homeless Health. Our services can't all just stop. They can't all become virtual. In fact, what we're finding is we're doing more outreach. We're going in sort of search for our community. We're looking out for those that are more vulnerable and for those that are at more risk of these health inequities.
Yeah, that's a good point. We'll come back to some of the other issues in relation to mental health, but for now, if I can turn to you, Courtney, this is a broad question in a way, and as a nurse, and I know that a lot of your your close friends and a lot of your close colleagues are some of the frontline nurses, some involved actually directly in COVID treatment. But I wanted to get a picture from you, a first-hand picture and a perspective of your own perspective, but that of your friends and your colleagues, about what it's like on the front line treating COVID patients in particular. Talk us through the preparation. We all hear about PPE. Are staff feeling confident on that front? Is there a sense that we've got this? Is there perhaps a worry about the unknown? What's your sense in terms of the frontline colleagues of yours?
Yeah, we were actually we're talking about this today, and we were sort of complimenting the staff on the ward about the camaraderie between the teams. And it's really nice to see how they work together and work as a team and ensure that everyone is safe before they're going into rooms, and make sure they're safe when they're coming out of the rooms and doffing their PPE. And it's really nice to see. It's we're really working quite closely with the wider MDT, and I think that's been a really important step this time around. We've made sure that we've got twice weekly MDT meetings with physios, dietitians, speech path, the medical team, the nursing team. We've really incorporated all of these people into patients' care. Of course, there's still some anxieties around caring for patients with COVID, and there is still a little bit of fear, of course, in what's going on in the community, and a bit of concern for their families as well. And that's completely justified. But they're working really well as a team with each other, and their communication is exceptional. So it's big kudos to the team on the front line there.
Yeah, it does. I must say, as a non-clinician, the thing that strikes me, and I saw it prior to COVID, but I think COVID certainly amplified that sense. You use the word MDT, and for those of you, that's a multidisciplinary team approach. And I must say, even reflected in the panelists right now, but I've never seen such collegiality in my life, and the different people with various expertise working together, listening to one another, and that I could not begin to imagine the type of agility and the pivoting that St Vincent's has shown. I couldn't picture that occur in any other environment, but this very collegiate approach that we've seen. It seems to have worked really well. I wanted to ask you on that note, how do you move an infected patient? Obviously, if a patient presented through emergency and they needed to go to ICU or a ward, how does that actually physically happen?
Yeah, that's actually something that we did some filming last week to sort of make it really clear what that process is and the responsibilities of the team who do that. So we've got an intra-departmental transfer process that's available on SharePoint. And so what the ward staff do, for example, so if there was a patient on the ward and we were needing to go to medical imaging, for example, the ward staff ring switch and activate a COVID transfer. And so they obviously outline where the patient's coming from and where they're going to. And that sends off a page or a phone call to security, environmental services, and then of course medical imaging. And it's a really coordinated approach to transferring that patient safely throughout the hospital. So again, it's different teams working together to make sure that we've got a safe process for making sure that not only the patient but our staff and our families are kept safe.
I understand that St Vincent's is looking to obtain some bubble rooms and also air scrubbers to enhance air purification in wards. Can you explain the importance of those two, how those two mechanisms work, and yeah, I guess just the practical, because to me air scrubbers seems an irrational kind of concept. So if you could talk us through that.
Yeah, it's pretty impressive technology, and for anyone that's seen the bubbles, so we've got two bubbles in the hospital at the moment. So there's one on 7 North and one on 10 North, and they're super impressive. They're purchased from a German company. They're French design and manufacture, and so it's essentially plastic that is fitted to any space that can turn that space into a negative pressure environment. And so they're fixed to the outside of a 4-bedded room on 7 North and 10 North. And then there's 2 zipper sections essentially, and there's an antechamber room, and then of course the bedroom, which is converted to a negative pressure room. So there's a filter that is located on the outside of the room. And so filtered air is drawn into the negative pressure room whilst the contaminated air is sucked out, and it goes through a HEPA filtration system. So it's really impressive technology. And so the UV light, it's called a UV angel, and essentially they're fixed to the roof of whichever sort of area that you're wanting to fix them to. But let's use Seven North as an example. So the filters are fixed every 25 squared meters. And basically it sucks the air into the filter. It kills any bugs that's in the air, and then filters out clean air around the ward.
Wow.
Yeah.
Danielle, if I can move to you, I know you've been involved in our kind of disaster response. You're our disaster manager, and you've had your work cut out the past 18 months. But one of the things that, you know, for any of us who talk and engage with friends overseas, a lot of them marvel at the response in Australia. It's certainly often been a beacon of light in terms of the minimising the impact here across the Australian landscape. I know we're not, the picture isn't so perfect at the moment, that's for certain, but I wanted you to talk through some of the crisis preparations that you've been involved with that kind of helped minimise the impact that we've seen. Obviously, St Vincent's from the outset found itself in quite an epicentre in the early days of COVID, and even now with this new strain. But I was just going to ask you about some of that crisis preparation, what it's entailed, and what we've learnt in recent times, and perhaps what we've learnt from other communities, other societies throughout the world.
Yeah, so I guess for those of you watching, we have our Emergency Operations Centre, and you'll hear us say, oh, the EOC. And basically what happens is we switch from a business as usual management structure and organisation around the hospital. And what we do is we have an incident management team that takes on very specific roles to manage our response and our planning forward and things like that. And so pre-COVID, whenever that happened to be, we would train people up to take on those roles. So planning logistics, media and comms, very key roles in, you know, making sure the hospital continues to run irrespective of what's actually happening outside. And we would have annual exercises and all of those sorts of things just to make sure that should anything happen, that people across our organisation already had the skills to step in and sort of take over that really agile, flexible response to whatever happened to be happening. So along came COVID, and we've really tested all of our staff, all of our colleagues across the organisation, and it's been spectacular to see, as Sean mentioned, you know, we have a huge variety of staff who can now step into those management roles and lead our organisation irrespective of what's happening, even if there's a dragon on the roof, and some days that's what it feels like. And so they really are able to sit outside of those business as usual process and make sure that, you know, what we're doing today and then what we may need to do as things change on a daily basis are covered off.
One of the things that I've noticed St Vincent's was one of the first, if not the first, in Sydney community pop-up testing centres. We set it up at Bondi Pavilion, and then you kind of pivoted and converted it into a mass scale drive-through at Bondi. But I remember in the early days, or certainly last year, when we were testing, the testing numbers, even during some you know, clusters and so forth, we were talking around 20,000 tests throughout the state. Now I've noticed the numbers are the last few days, I think it's been over 100,000 people getting tested throughout New South Wales. Obviously, St Vincent's and SIDPAP have played a really major role in that scaled up response. Can you talk us through how did that kind of rapid scaling up happen? Because it seems to have taken hold in the last few months.
Yeah, I think back to the first days where there was a couple of us in a room just trying to figure out what we were doing. And, you know, we're really lucky to have the support of people like Gail and our lab to really get that up and running. And then, you know, being competitive as we are, we're always keeping tallies of what our bests were. And, you know, a couple of weeks ago at Bondi, we had over 4,000 people come through that testing clinic, which are numbers that, you know, we couldn't even imagine 18 months ago. And I guess really it's important to recognize that it's not just, you know, the people putting the swabs in the noses, and it's not just, you know, there's collectors and there's admin and there's couriers, and then there's the amazing lab staff. Like, I just, you know, I can never, you know, take my hat off enough to the labs for ramping up from, you know, new technology, what was 18 months ago, a new test system 18 months ago, to now just being able to process, you know, tens of thousands of swabs, which is just amazing. And then, you know, having other people come in and say, hey, we're looking at your systems and we think there's a way we can do it better. So, you know, from writing on forms and writing on tubes, we now have our FPOS system, which is just phenomenal. So we take people's mobile numbers, we punch them into, it's literally an FPOS machine. It sends them a text message, they enter their details, it gives them a unique code. We then validate that back in the machine and out pops their stickers. So it's reduced the time that people need to be tested, like, so significantly. What used to be, you know, 15, 20-minute process is literally seconds, as quickly as people can enter their details into their own phones. And that's really just given us the capacity to ramp it up. So we've made efficiencies at the front end, but then at the back end as well. And like, if you wander up to SIDPATH in the middle of the night, you'll be shocked by how many people are actually up there working 24/7 to make sure that their turnaround time on those tests is state's best.
On that note, and Gail, you might want to chime in on this as well, but Danielle, can you talk us through the importance and the latest development in rapid testing? This seems to be a hot topic at the moment, and its importance seems to be increasing quite rapidly. But I'd love to get Gail's view as well in terms of accuracy and the difference in terms of antigen testing as well. But Dan, if I can open with you in terms of what you see its kind of utility in terms of current testing patterns.
I guess really it's about making testing as simple and efficient and as effective as possible. So we need to make sure that what we're offering people is accurate, but it's also, you know, to reduce the burden on the individual to get tested. So if we can make the experience through the clinics much more effective and efficient, that's fantastic. You're encouraging people to come and get tested. New testing technologies that are, you know, less invasive for people. Again, it's reducing that burden on the individual and on the communities to come out and get tested. But I'm going to fling to Gail onto the technical aspects of all of that, because I'm literally just the person that puts the swab in the nose.
Thanks, Danielle. No, it's fine. So I think when we talk about rapid tests, we can think about it in all different kinds of in all different kinds of sort of senses. I think within the hospital, what we have been using is rapid tests, which have a very quick turnaround time to make decisions. Am I on mute? No, somebody just said it was on. Somebody's just talking to me saying I'm on mute. Okay, so in the hospital, we can do the PCR test, but we can do them as a rapid test, which means we can turn a result around in sort of, you know, a couple of hours maximum, as opposed to 7-8 hours. And that means we can make really important decisions about patient management, patient flow, because obviously we do a lot of tests on people that are negative. A lot of people come in and we have to consider whether they could have COVID. The majority of them don't, and we need to then make sure we manage those people appropriately and move them through departments. So using a rapid test to be able to very accurately, very quickly tell us whether somebody's got COVID or not has been incredibly important in the hospital setting. Those are PCR tests, though. We don't use those tests outside of certain situations in the large-scale testing that Danielle's talking about, because they are limited in number, and we have to carefully consider where they can be best used that is going to have the maximum impact on patient management. I think there's a whole lot of other sort of considerations around rapid testing, such as rapid antigen testing, and different forms of testing, such as saliva testing, etc., which absolutely we should be exploring how these tests can be used. And it's likely, I think, as we go forward, that different kinds of tests will have a different kind of place. There won't be just one test or another test. They'll all have a role to play. And what needs to be carefully considered, obviously, when you roll these tests out is how they perform. So, and how they perform in certain populations that may be asymptomatic or symptomatic, and in populations with low prevalence or high prevalence. And they all have different performance characteristics depending on what that population looks like. So what you don't want to do is roll out an easy test, but find you're missing lots of people, right? Because that would be a disaster. So you have to consider all these things. And I think there's a lot of work going on to consider exactly what the place of all these different tests are as we sort of, enlarge and roll out testing. So I think that's a sort of a work in progress, but I think will certainly happen, and it will certainly be welcomed when it does.
Sounds like it's about getting that balance right as well. Moving away from testing onto vaccinations now, Gail, can you talk us through the latest findings in terms of vaccine efficacy and some of the decision making for those who haven't had the opportunity to get vaccinated just yet, how they should come to their decision in terms of which vaccine?
So vaccines are in some ways very simple and in some ways very complex. There's a lot of data out there and new statistics are being thrown around, all the time, and this versus that and so on. And it can get really confusing. And for even people who have a bit of knowledge, let alone sort of the average sort of man in the street. So I think there's clear messages, right? The first message and the clearest message is that whatever vaccine you have, when you have that vaccine and you've completed, your 2 courses, you have a 95% chance or reduction in your chance of getting hospitalized or of death, all right, at least. And so we know that very, very clearly. If you look at our stats, if you look at the people in hospital now, if you look at the people in hospital in the US, in the UK, they are the unvaccinated population. Hardly anybody who is fully vaccinated is in hospital with a serious illness. And I think that's really important. That's the key message, because it will stop you getting sick and it will stop the hospitals getting overloaded. Now, in terms of then the other sort of aspects of vaccination, there's a few other things to remember, so just having 1 dose is not enough, and it will give you some protection, probably around 30-40%, something like that, but it's not enough to be fully vaccinated. So it is really important to have the second vaccination. That gives us a longer and a better immune response. So that's why we try and encourage people to have the second vaccination, and it's the reason why the AstraZeneca doses the second dose has been brought forward to try and quicken or hasten that sort of fuller immunity. But the other thing, if you look at the Pfizer, in fact, pushing out the Pfizer a little bit, which is what sometimes we may have to do depending on how much vaccine there is, still gives you just as good, immunity, in fact, maybe even better. So it doesn't matter if you push out your 3 weeks to 5 to 6 weeks. So there are some complexities there around dosing of vaccine that are still being worked through, but it's really important to remember, just to get vaccinated. That's the most important thing you can do, to get vaccinated with whatever vaccine obviously is available, provided you haven't got a reason not to, and to get both those doses in when you can get them in. I mean, those are my main sort of messages, I think.
In terms of long-term trends of vaccination, do you foresee a situation down the track where we will need to get booster shots, similar in a way to the flu vaccination?
Yeah, look, I think absolutely. I think there's almost no doubt that will not, that won't be the case. So it will be the case that we'll have to get booster shots. One of the advantages we've got with our delayed vaccination rollout is that other countries will be answering this question way before we probably need to get around to our booster shots, because they're so far ahead of us in their sort of vaccine rollouts. But I think it's very likely that we will need to continue to have booster shots. It's very likely that we'll probably have a mix and match of vaccines, and there's some data coming out to suggest that the best way to provide ongoing immunity is to use different combinations of vaccine, because they slightly target different areas of the virus. So it's teaching your body to learn how to see the virus in different ways, which is what it needs to do for what we call breadth of immunity. And that's really important as the variants come through as well. And they'll need to change the boosters and the vaccines as new variants come through, which again, undoubtedly they will. So
it's sometimes so easy to forget about the intricate technology in the vaccination. Having received both my jabs, you look at this tiny vial and it looks so innocent, but it's extraordinary what's gone into it to make it work so effectively. And it's something that I think we sometimes forget. Gail, shifting to the ADAPT study and some of the long-term kind of findings that you've been able to look into so far, I was hoping you could talk through some of the top line kind of things that you're seeing in this longitudinal ADAPT study that you've been conducting, I think, for well over a year now. And then also, are you noticing any changes in terms of variant changes, or do you get a sense that those long-term impacts are fairly much going to be the same?
Yeah, so the ADAPT study was set up really quite in the very early days of the pandemic last year. So I think we actually got ethics approval in April, and our first participant came in very soon after that. And those people were from that sort of first, Bondi sort of waves. If you remember back, the Bondi backpackers and the people returning from the ski fields, etc. So we had a lot of those people, and it was really amazing how many people were prepared to take part in that study, which at the time we had no idea that there would be something called long COVID. It really was that we sort of thought we ought to sort of see what happened to these people, and it was a great collaboration actually between thoracic medicine, infectious diseases, neurology, immunology, again bringing lots of people together to really get the most out of most benefit for the patients out of this, rather than everybody trying to do different things. And I have to acknowledge I should acknowledge here before I forget, which I sometimes do, that the support we got from the Curran Foundation and St Vincent's Clinic has been critical to actually keeping this cohort going. But we've now got, well, it keeps growing because we're enrolling again at the moment, but it was 147 people that we've been following at various intervals since April 2020. So they're about sort of 15 months out now. We've had almost very few people drop out. They give a huge amount of their time, their blood, and all kinds of other body substances you don't want to know about to us, so that we can really try and understand what's sort of going on and actually what's driving long COVID. Because obviously during the period of this study, what happened was that we and others, again globally, were realizing that some people weren't really getting fully better. And in fact, we've looked and reported on our cohort, and it's around, at a year, it's still around 20%, 15-20%, 1 in 4 or 5 people who say they're not back to full health. And so a lot of these people have got what's called long COVID. It's a whole range of a lot of symptoms, but typically it's persistent fatigue, which comes and goes, some chest pain, some shortness of breath, maybe some brain fog. These are the common symptoms of long COVID, but it can be lots of other symptoms. What we're trying to do now, and what we've got some really interesting data coming out from, and in collaboration with my colleagues, my immunology colleagues at Kirby Institute are doing this work, looking to see whether there's an immunological signal for people post-COVID. And it seems that there actually is a signal. We've got a paper out at preprint at the moment, but it's under review. But it seems that there may be something in people's immune systems ongoing at least 8 months post-COVID that may be driving some of this syndrome. So some really, I think it's cutting edge, research coming out of this study. So I think it's been a great outcome.
It's phenomenal, the insights that you've been able to get, and there's no, it makes absolute sense that I've been getting calls from all over the world from journalists asking for your insights, because it's extraordinary the foresight that you and the team had to set it up and start to be able to get this intel, get this data to help drive and inform decision making around COVID response and treatment. Sean, if I can move to you, tell us about the Safe Haven pilot and its role in hopefully preventing suicide.
Yeah, the Safe Haven is a cafe-style after-hours alternative to an emergency department to support people experiencing distress. And I mentioned earlier, we're seeing and we're hearing from a lot more people who are in distress. That the service is designed to be supported by people with lived experience of mental health, and that's to provide a peer support approach to how we deliver care. Look, the Safe Haven's up and it's running and it's in a pilot phase, and like really pleasingly, and through the support from the Curran, we've been able to make some real clear gains with our community and support people in a way that we otherwise wouldn't have been able to. I mean, just as recently as last week, we had a consumer come in who reported to the team actually after having attended a couple of times that had it not been for the intervention that was on offer, they were pretty confident they were going to take their life actually, which is really awful to hear, that if we didn't have that service in place, we could have had somebody who wasn't able to kind of fulfill living their life and live that fully. The service, ideally, we'd be having it run 7 evenings a week over weekends. At the moment, we're a little bit limited. We're running it on 3 to 4 evenings a week. And, being conscious of COVID, we're doing it by an invitation only. But we're really invested in working with our local community and those around the area who need that additional support.
There's another really innovative mental health intervention that I know you've been involved in, and I'd love to get a better picture of it, the Urban Health Hub. Can you talk us through that? And am I right in thinking that both those initiatives, Safe Haven and Urban Health Hub, will, in the long term, are going to be located in the former Green Park pub? Is that right?
Yeah, no, absolutely. Yeah, so both of those services will eventually be located at the Green Park Hotel. And so the Safe Haven, that'll be an after-hours support service specific to people with distress associated with self-harm and suicide. The Urban Health Centre, that is a real opportunity for us as a mental health provider to work with the community in a different and an innovative way. What we're often finding, and it's over-reported, is that we've got this missing middle, this missing group of people who are they can access support and care through their GP. They're often put on long waiting lists to get psychological intervention and support, or they're not quite acute enough to access a service that we would typically provide in one of our specialist community services or in our inpatient care system. It's also a service which has got great research potential and capability, but most importantly, I think it's a real opportunity to engage and interact with the community in a way that starts to destigmatize mental health. Now, unfortunately, stigma still does exist with mental health. People are still having challenges accessing the appropriate amount of mental health support and get mental health intervention in a meaningful way, which leads to longer term improved mental health outcomes. The Urban Health Centre, that will be a place where anyone can pop in, and they can undergo a level of assessment and intervention. And how we envisage that space as being a real opportunity to really start to redirect, I should say, the kind of the narrative around mental health and how St Vincent engages with our community.
So am I right, Sean, that there's no coincidence that we looked at the Green Park as a beautiful historical building that is the warmth of a pub environment and creating that very welcoming, destigmatized environment? Is that central to your thinking for both of these initiatives?
It's absolutely central that we find a place, and the Green Park is the perfect opportunity, which allows for an invitation for people to come in and access mental health care in a way which is sensitive. Unfortunately, we have got a consumer group who are vulnerable. I think there's still, as I've mentioned, an unfortunate shared experience that, when you go into the O'Brien Centre, oh, you must have something really wrong with you, you must be using substances, or you must be taking medication for that really severe mental health problem. Firstly, that's often not the case at all. But that's a group of people we're already engaging with and we're doing really meaningful work with. This is our next ambitious community venture. It's a space which we're going to be able to step into, and one of the key points of this service is that it's going to be co-designed with the community. So it's going to be taking the community on a journey in partnership with St Vincent's Mental Health Service and the Homeless Health Service and the Drug and Alcohol Service, and designing a service which fulfills the community need, not a need that we necessarily foresee. We certainly have some very good ideas as to what we need to be doing to intervene meaningfully in the community, but we want to invite the community to participate in that process of designing services.
Probably, Courtney, if you don't mind talking about impacts on the community and some of the distress we're seeing. At the moment, St Vincent's has a no visitor, or predominantly no visitor policy. I totally understand, and it makes absolute sense in terms of minimising the footprint and minimising risk of infection. But obviously you and many of your nursing colleagues in particular, all the clinicians who are treating patients, you're seeing firsthand some of the distress, no doubt, that's causing not only the patients themselves, but their loved ones. Can you talk us through what kind of impact that's having and some of the supports we might have in place to overcome some of those challenges?
Yeah, absolutely. I think, as you say, it is quite distressing for the patients and their families, and for a lot of nursing staff. It is something that doesn't quite sit well, when we usually involve families in the patient's care and their sort of discharge planning. And that's still really important to the nursing staff. So we've looked at other avenues to involve patients and their families in their care. We're using iPads that have been made available, which is great. So that's something that we've used quite regularly during the COVID times. We've used them quite recently, actually, with a gentleman who wanted to FaceTime his family. And that was something that was really important to him. And it was also really important for the nursing staff to be able to facilitate that interaction. As Sean would attest to, it's quite a difficult thing for a patient to sit in either a single room or within a bubble and not have any interaction except for the sort of the reduced interaction that they would have with the nursing staff and the medical team. So it is a really difficult time for people, and we completely acknowledge that. It's just a completely difficult time for everybody. But I think the nursing staff have done a really great job at involving families where they can. And again, the medical team have done an exceptional job at making sure that the families are kept up to date with what the plan of care is and what the trajectory is. So it's something that, again, it's that coordination of care that's been really important.
Absolutely. Dan, if I can turn to you, the other day I saw you driving out of the hospital the other morning in a very nifty looking van, and I wanted you to talk us through where were you going and what was this van that you were driving. It looked very impressive.
Oh, that's our wonderful Vax van, which was kindly donated to us by the Curran Foundation to support our outreach work in the vaccination program. And it has really been a game changer for us. It's also taken the load off my car. We commenced, it was 11 weeks ago tomorrow, actually, our first homeless health vaccination outreach hub in partnership with Kirkton Road Centre, City of Sydney, St Vincent de Paul, NEMI, basically the homelessness coalition across the Sydney metropolitan area, because we identified very quickly that COVID in the population locally who are experiencing homelessness or at risk of homelessness would have catastrophic consequences. And we also knew straight off the bat that this most vulnerable population quite often, has difficulty engaging in mainstream healthcare services, and you know, the finer complexities around getting into a vaccination hub, engaging in the technology that's required to make bookings and things like that, that it would be a much better idea to take vaccinations to the people. And so it's been just the most amazing collaborative project I think that I've ever worked on professionally. It really has been a coming together of all of these services to provide vaccinations to some of the most vulnerable people in our local community. And every week now we're vaccinating in excess of 300 people just through that one hub. And you know, I approached the Curran Foundation for their support in getting a van for us that would allow us to pack everything that we need to go out and vaccinate people. And so, yes, the Vax van arrived a couple of weeks ago, and it's been amazing. We have our Thursday hubs. This week, we've just kicked off 2 more social housing hubs in collaboration with South East Sydney and Kirkton Road Centre. So we're doing social housing hubs at Northcote in Surrey Hills, and on Fridays at Lexington down in Maroubra, really targeting those populations to make sure that there's really good uptake of vaccine. And then on the other days, we've got a variety of outreach. So we're doing residential aged care facilities, making sure that all of the residents and staff across St Vincent's care services and some other local residential aged care facilities have adequate protection. And we're also working with frontline workers through the police and all of those sorts of things. So wherever we can identify a gap in our vaccine program, we really working collaboratively across Greater Sydney to see how we can, you know, get vaccines to the people, because as Gail said, that's really the game changer for us.
And you know, David, if I may, I think this is really St Vincent's supporting St Vincent's staff to fulfil and live out its mission and values, which I must say is not something I've observed across the state, and certainly has not been as proactively led as Danielle and others have done in this space. And just a comment, you know, the feedback from the ability to create that equity of access has just been fantastic. These teams are out there really working proactively in and amongst the community to make sure that these vulnerable people are looked after and cared for, and given priority and preferential treatment as they should, given the vulnerabilities Danielle's described.
Look, Sean, I think on that note, I've been a terrible timekeeper, but to your point, and what you've discussed in the course of this discussion today, what Danielle's just pointed out in terms of our going out to the community, particularly the vulnerable, what Gail has talked us through in terms of the long-term, this kind of visionary approach that was adopted so early in the piece, because I remember asking Gail questions about the ADAPT study at our first virtual Inside St Vincent's discussion. And I was thinking to myself very cynically, and very wrongly, mind you, who's got the time to be doing research when it's happening on the ground? But boy, was I proven wrong, and was Gail's vision proven so fortuitous to be starting to get this long-term picture. To hear from Courtney about the first person experience of herself and many of her colleagues, to me, it just really highlights the compassion and that very human approach, and also the multidisciplinary approach to see everyone coming together in such a way. I just, Sean, coming back to your comments and how proud it's made you feel as a St Vincent staff member, I want to just say, as we wrap up, and I know we've gone a little bit over time, but the St Vincent's Curran Foundation is about to launch a campaign to raise at least $5 million over the next 2 years to support new and essential mental health programs, responding to the increased demand from our community. The funds raised will help establish the new urban health hub and the Safe Haven suicide prevention centres, and it will help refurbish our Caritas acute mental health unit. There will also, this fund will also support some of the additional therapeutic programs at U Space, our youth mental health service. So if you're in a position to support these services, I'd really strongly encourage you to get onto the St Vincent's Curran website and support these really critically important mental health interventions. I feel very proud being part of this webinar. I've been involved in quite a few, but to be surrounded, and unfortunately I'm staring at a screen, so I'm not physically surrounded by our 4 panelists, but we're all in the same room or the same office department at the moment. And I feel very proud to be part of this team, to be part of this multi-pronged intervention. And, you know, going back to your point, Sean, about the mission of the sisters and going out to community need and responding to community need, I can't think of any greater example than what all 4 of you have spoken to today. All of these initiatives are really what the sisters' mission and values charged us with. And clearly they didn't have COVID-19 in mind, but we saw a bit of a snapshot with the Spanish flu in 1919 and how the sisters responded then. Maybe that has been a beacon of light for how we've responded today. But either way, one of the great unifiers in all that you've done, because all 4 of you have been involved in quite eclectic ways, but the great unifier I think we'd all agree upon is the role that the St Vincent's Curran Foundation has played in being the great enabler, being the great differentiator for us to be able to do a lot of this kind of pioneering work. And for that, I'm eternally grateful to all 4 of you, but to our community and to the St Vincent's Curran Foundation. And thank you very much for this initiative in setting up this new fundraising campaign. Sean, I'm sure you've spoken so eloquently to how these particular 2 projects can make important interventions to our vulnerable, and particularly the missing middle that you touched on. This is a really critical kind of initiative and a part of the community that we've missed in the past. And I think it's terrific on St Vincent's part to take this initiative and be starting to make these interventions at such a critical time to yield such an important result. So panelists, thank you so much for joining us today. And to our audience, I'm sorry for going over time. It's really been wonderful having you with us, and hopefully see you soon in slightly better times. Thanks so much.